Well, thanks so much. I really appreciate the opportunity to talk to you about some of the progress that we've made in the group system, amplifying the points that Monica and Jim have made so far. This is once again a reiteration of the major goals of the IOM recommendations. I don't really think I have to amplify those, but as Jim pointed out and Monica mentioned, I think we've made progress in basically all of these areas of one sort or another. We all have our favorite quote from the IOM report, and this is mine. The committee concluded that a robust standing clinical trials network is essential to effectively translate discoveries into clinical benefits for patients, and it's imperative to preserve and strengthen the unique capabilities of the Cooperative Group program as a vital component in NCI's translational continuum. And this is from the perspective of someone that started working in the groups as a staff associate in the cancer therapy evaluation branch before the CCAP, but it was a branch in 1972 to 74. And I think that we have, as been mentioned before, have seen through those years from the 50s onwards, the fact that this system, in spite of all of its reviews and all of its problems, has been able to be the major force in changing the standard of care in this country and the world. What are the characteristics of this success? They are the loyalty and commitment of the entire cancer community, cancer centers, academic community physicians to enter their patients. It's a commitment and involvement of our patients. Throughout the cooperative group system, we have at any given time about 100 advocates that are working directly with us in the development of trials and the review of trials. Strong participation of clinical and laboratory scientists, the willingness to work as a team, the commitment to the public good, and it's a key interface with industry. And it is also a system that's able to leverage NCI dollars. So this is the one spot where all the various forces in cancer come together in the NCI's extramural program to really move the whole field forward. Through the process, the group chairs came up with what we felt were the guiding principles that we should move forward with, along with the NCI in developing the new network. And you've seen these before. I've mentioned them in the 2 or 3 times that we've talked here. One is that the patients are best served by strong scientific programs, and the groups are an integrated hub for phase 3 and large phase 2 trials. That there should be flexibility as we developed our restructuring, or flexibility to maximize our potential. That the field is really best served by a strong membership culture. The review process should incentivize scientific innovation. The viabilities of the groups are obviously linked to the resources, and multi-sector involvement generates science that would not otherwise happen. That is involvement of the ones that I've mentioned before, but also industry, laboratory scientists, and the various components within the NCI structure. So, as has been mentioned, we have gone through this process, and the system has been reconfigured. The first on the block was the Alliance for Clinical Trials that brought together the CLGB, NCCTG, and ACOSOG, American College of Surgeons Oncology Group. The Children's Oncology Group has restructured many, many years ago. ECOG Akron Cancer Research Group is the combination of the Eastern Cooperative Oncology Group and the American College of Radiology Imaging Network. We felt that there was an opportunity to really strengthen ECOG, which was one of the initial members as well in that 1956 statement, and actually it was the Senate Finance Committee that established these groups. So it was the Acute Leukemia Group A, Acute Leukemia Group B, and the Eastern Solid Tumor Group, which became the ECOG. So we felt that we could really strengthen ECOG and Akron by bringing it together. And NRG, the NSABP, RTOG, and GOG, and SWOG are the 5 groups. And I'm happy to hear that there were 5 applications. Not 4, not 6, 5. So this is a slide that Jim showed. This is more updated than mine. But I think the key thing to keep in mind is that every conceivable holiday from Thanksgiving to New Year's was consumed by this process. And we all made it, and in fact, the review will occur in the summer, and we're anxious to really get this over and started. So, now here's a slide that was presented to the BSA, the Board of Scientific Counselors, actually, when the FOA was approved. And there was a budget discussion that was associated with that. And it was really, I think, remarkable for those of us who were there when this program was discussed, that Dr. Varmus stated his commitment to try to enhance the financial aspect of this process. So our baseline funding is roughly $152 million, and there was a proposal to increase that by about $25 million. To a total of $178 million. Obviously, we're in tough economic times, but I think there was a strong commitment made that if the funds were available, that there would be a commitment to try to enhance those funds. This is the slide you saw from Jim about the various FOAs, including the Operations Center, statistical offices, the Canadian Collaboration Network, Integrated Translational Science Award, RT Imaging and Core Services, and lead academic and participating sites. I'll focus on a couple of these because I think they really provided great opportunities for us to really move the whole program forward. So the group's operation centers, there will be basically 5 that are coordinated in various degrees, are really the hub of the whole system. We have the Integrated Translational Science Centers, which I'll talk more about, the lead academic participating sites, our stats and data management centers, which are now coordinated across the reconfigured groups, the RT and imaging cores in the Canadian Collaborating Network, where each of us historically and currently do interact with the Canadian network in trying to facilitate the studies that are done by them or also by us in their trials. This is just a look at the system, and it's over 3,100 institutions, 14,000 investigators across the United States, and also it involves international participation. And these dots are represented to a great extent by community sites, as well as by academic sites, and the community practices in this country associated with the CCAP program and with the affiliates and minority-based CCAPs and affiliates of main academic institutions account for about 50 to 60% of the accrual onto these trials. So this network idea is really, really important, and the community involvement is essential. You'll see that there has been a decline in the number of accruals over the years. And it's actually a stated proposition that the accrual should be around 20,000 per year, down from a high really in the several years ago of almost 28,000. Also, if you look across this, about 15% of the studies were phase 2 trials. That is changing as well with an increase in phase 2 studies. These are the numbers from 2011, and a couple points on this slide. One is that, so it was around 19,000. We just came back from a meeting with Meg Mooney and Jeff. It's about 21,000 this year. But look, if you do the proportionality here, the phase 2 trials, they account for maybe not 15%, but up to 20, 25%. So we're having fewer trials. We're having more phase 2 studies and more complicated studies. And it do have implications as we move forward, I think. Next. And this is just a look from the last data that I had of the activities of the steering committees. So since their inception in 2007, roughly 223, this is up to early 2012, 223 were evaluated and about half were approved. And as Jim mentioned, Bob Diazio will be speaking about the activities of the CTAC Translational Research Advisory Committee. And actually, that gives us an opportunity as the group chairs to look at the whole portfolio, along with everyone else. And it gives us an opportunity to look at strengths, look at weaknesses, talk together, and come up with plans to try to strengthen the whole process. And we're committed to do that. So if you look at the portfolio that's in development, and I guess Bob will speak more about that. Excuse me. There's no question there are more phase 2 studies. And we really need the community involvement for the phase 2 studies as well as for the phase 3 studies. Excuse me. I should have done my voice exercises before I started. But and the point I want to make here is that, and this may come up during the panel discussion, there's been a long-standing sort of, not say it's a tradition, but many CCAPs and community sites hesitate to open phase 2 studies because they tended to be small, they opened and closed quickly, and they didn't view that that's the way to commit the resources. But we really, really need their involvement in these larger phase 2 studies. And I think that means that the CIRB ought to evaluate all of those phase 2 studies so that they can be rapidly activated. And the CTSU ought to be the support system for the phase 2s as well as for the phase 3s. And these are more complicated phase 2s, and they're essential to drive the whole system forward. There are fewer large phase 3 trials, but when you look at the era of precision medicine for metastatic disease patients, it's not always clear that the same precision directed approach works and is available for the adjuvant type studies. In fact, most of the studies that have looked at the manure agents are negative. So there's still going to need to be large phase 3 trials when we get a really solid lead and we focus in on what groups we want to evaluate. And also in the development of targeted combinations. Major issues with biomarker screening. But I do think that this whole process will provide an opportunity to really position the groups within the network in a critical role with regards to the development of more targeted therapies. One example is a study that we are discussing now, which is a study that involves adjuvant lung study for EGFR mutants that the Alliance is going to run, for ALK mutants that ECOG Akron is going to run, and it's going to take about 7,000 or 8,000 patients screened in order to get the 800 or so patients that we need on the study. So we're hoping, and Jeff is working very hard on this, I think everyone is working hard on it, to really engage the Center for Cancer Genomics with us so that we can, in those screened patients, really get a prospective, well-annotated group to follow as we also find through that screening the patients that we really want to put on who have EGFR and ALK mutations. So I think that's a great opportunity for interaction. This is, I've talked about clinical trials, accruals, about the number of trials, and this is just a depiction of, when we talk about clinical trials, it's really the nidus for our work across the entire system. So the patients are involved and interested in our studies because it provides the opportunity for cutting-edge care. They are willing to donate their specimens and also participate in the process because of that. Basic and translational scientists are interested in our studies because we have highly annotated specimens, images, clinical data. The clinical scientists in the cancer centers and academic sites have an opportunity to bring the trials forward and move their ideas through the system on a national, international level. And many of us in the room have been authors on studies in the most preeminent medical journals, and our careers have been unbelievably moved forward by that. And the community clinicians are interested because it gives access to cutting edge care. and they contribute accrual, and they can influence study design. So the clinical trial is really the nidus that the pearl comes from. And so the better they are, the best fashion they are, the most cutting edge they are, will, I think, rule the day here. But we can't, there's a certain amount of fuel that you need in the system. We can't let the clinical trials just go, you know, we end up doing 30 or 40 studies, and we end up with 10,000 patients accrued as opposed to 20,000. There is a certain balance here. That's my point. Moving on to the RDE, Jim mentioned this, and we're all very proud that we have this system. We work so hard together in all sorts of different ways to make this happen, and it is a reality. But really, that's just the start. And you know, what we really need, and what we are actually in the process of devising and designing in ECOG Akron, because Akron has such a tremendous IT platform. You know, they've always been electronically based, but more importantly, they have terabytes of data with regards to imaging. Is we're in the process of developing, which we'd make available to everyone, an integrated data warehouse where the CRF data, imaging data, tissue specimen repository inventories integrated with what Jim mentioned, digital pathology, omics, can all come together. And this is an idealized cartoon of what we're developing, which includes the roster clinical trial data, biospecimen lab data, imaging data, and the various outputs and operations, analytics, dashboards, and research. And from the inception of the ECOG Akron idea, we had always envisioned this as a great opportunity, and a great opportunity not just for us, but for the whole system. I'll just finish mentioning two things that I thought were really important. One is the lead academic participating site opportunity. As Jim mentioned, the Cancer Center guidelines have been changed. To his credit, we actually, this was a recommendation that myself and Shilsky, and I don't know who else, Wally, were in the room in 1997. We said, we need the Cancer Center guidelines changed. And he finally did it. Because we really needed that extra involvement and extra pressure to make sure that the cancer centers, which are the lifeblood of the group system, were engaged as strongly as possible. I think that this also, the opportunity provided better visibility and coordination across centers. I think gives us the opportunity for better engagement of the spores and UO1s. And obviously, there's better recruitment for high accruing sites. In the grant, we were asked to mention leveraging. I can only speak on this relative to the ECOG Akron program. So if you look back from 2007 to 2012, there are 83 peer-reviewed grants that directly relate to ECOG Akron trials, About 65 R1s, R21s, and others from the NIH, and 18 from foundations. So, you know, these grants are all based in our cancer centers for practical purposes, and they become part of the scientific nature of the centers as well as of the groups, and attracting the kinds of people I mentioned on that other cartoon. This is a slide which, once again, just relates to ECOG with regards to our core support. To point out, as has been mentioned by the IOM report and by others, that this is basically a hybrid system. If you look in three categories, personnel, biorepositories, and case reimbursement, roughly there's $100 million in that category from that time period. 45% came from, 55% came from the NCI, 45% came from extra NCI sources, about 38 million from industry, and 6.5 million from not-for-profits. So this is a system that really can leverage and get more bang for the NCI's buck as we work together. I want to focus in on the biorepositories because that's what I'm going to mention next. And so roughly it's pretty much the same, that if you look at the overall amount of money invested in biorepositories, about half comes from the NCI and half comes from other sources. And those biorepositories are the things that allow the translational science centers to actually operate. So there was this opportunity called Integrated Translational Science Centers in the FOA, which Monica really fought for, and I think that we all ended up agreeing with NCI that they were really, really important. So all the groups have applied. All these have involved integrating next-gen sequencing, advanced imaging, and immunobiology. They were put together by the cancer centers, SPORES, include academic partners, industry partners, for-profit partners like Foundation Medicine, academic partners like the Broad Institute, and it really helped, I think, move the integration of our translational science forward. This is just a cartoon showing the intrinsic nature of our group biorepositories and reference labs, and they are a precious resource with excellent clinical annotation, large-scale trials linked to group biostatistics, and now the technology is available for FFP next-gen sequencing. We have studies that are very mature that have specimens which now can be used to deeply study the genetic processes. The FOA for the group banks are not out yet, but I think on the part of the chairs, we're committed to national distribution as we have always been. And those grants are supported not just by for ECOG investigators that I mentioned, but for everyone. Key linkages, as I mentioned, to biostatistics, group management, and in-kind support. So in summary, the restructuring is a work that's deeply, deeply in progress, and we've all made a commitment in good faith to move this system forward, and we're all proud of what we've done together. The process itself has led, I think, to a better understanding of our own strengths and weaknesses and opportunities. The new structure is overlaid on a system-wide adjustments which were essential and which we all committed ourselves to. I think that the restructured groups that will allow us to see our strengths and weaknesses and share platforms, as I've mentioned with regards to our IT plans. And it's a better potential for system-wide integration. We submitted the translational science grants with the Alliance. We have committed advanced imaging and advanced RT to work with energy. I mean, there are a lot of communications that are ongoing and essential. What are the challenges? And this was a slide that I showed at the IOM a while ago. I was very concerned that this reversion to the mean may lead to more homogeneity. I think we have to be careful of that, but I do think that the reconfiguration has their own personality, and I think that we are going to work more together, but still maintain our unique strengths. And we have to be very careful that with the steering committees, we don't tend towards the risk-averse kind of attitude. Accrual opportunities are decreasing, but that's the reality right now. If we don't have good infrastructure support, we'll all go on our different ways and directions. So I think to the extent that we can with the resources that we have, we ought to coordinate that. We need a comprehensive strategy for next-gen sequencing. Right now, we're all off on our own. We're making deals with companies and academic institutions because we have to, and we are going to do it. And whether we do it together as a coordinated program or not remains to be seen. We must maintain a high level of community participation, and the community has been and will always be essential to what we do. And of course, this major restructuring is at a time of financial constriction for the NCI, the centers, the groups, and the United States and the world, actually. So, but I think we're all committed to this, and we've worked through hard times before. So thanks for listening.
So thank you very much, Jim and Bob, for that great overview of how far the system has come since the report was first released. And now at the very end of this session, then leading into a panel discussion, we're going to hear from Warden McCaskill-Stevens, who's the chief of the Community Oncology and Prevention Trials Research Group in the DCP. because one of the next challenges that we'd all like to hear your feedback on is how do we really maintain the commitment and integration of the community centers into the research work of this new NCTN. So, Warda.